Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. I'm super excited for today's episode with Nate Denning. Nate is a physical therapist and founder of Integrated Performance, and he previously worked at Exos and the Minnesota Twins and did a sports residency, and he's been with so many amazing individuals and amazing groups, and he is a phenomenal physical therapist himself. And today we're focusing in on baseball, specifically return to sport criteria and progression criteria. So we talk about a variety of different assessments and other tools that you can use while working with your athletes to determine readiness to return to sport. And we also talk a lot about the importance of subjective readiness in addition to what you see objectively. Nate, welcome to the podcast. I'm super excited to have you on today, man. Thanks for being here.
Yeah, thanks, Dan. Super excited myself. Thank you for inviting me.
So for people who maybe aren't familiar with you, or maybe they haven't seen your past work with the Minnesota Twins or your current work and what you're doing in the private practice setting, would you mind filling them in a little bit about who you are and all that you've done?
Yeah, for sure. We can go kind of back to kind of by history of graduated PT school at Indiana University up at where I'm at right now in Indianapolis. Spent 3 years there, of course, for the DPT program, and then went down to Evansville for their sport residency with the guys out of there with Phil Plisky, Kyle Massel, Bethany Huber, and a bunch of great clinicians down there, and learned from them. Got some mentoring, and that's where I kind of entered the sports realm a little bit, as far as got to do some cool experiences doing some testing, FMS testing for D1 universities, and then also some Major League Baseball teams, organizations, and then some other organizations from there. Yeah, I was gonna say spent about 2 or 3 years there, or in Evansville, after I finished, or probably about 2 years after I finished the residency down there, just working in an outpatient clinic as a clinic manager, and then went down to Pensacola to work for Exos, which is a human performance company, which did a lot of NFL combine training, and worked with a bunch of our like SOCOM guys, special operations guys, and some professional athletes in the off season. And then from there, yeah, go ahead.
I was going to say, that's just awesome. That's a really incredible experience thus far. And, you know, you mentioned guys like Phil and Kyle. I mean, they are some of the best when it comes to the sports realm. So you've certainly been in great company this entire time.
Yeah, I owe them a huge thanks for everything that I do, and still talk with them a lot, obviously, and trying to pick their brain on a lot of things, because there's some fabulous minds down there in Evansville.
Yeah, definitely. And then you're kind of starting to transition there into what you did professionally, I think.
Yeah. So spent about 2.5 years down in Exos, just as the clinic manager down there for the Pensacola location. Like I said, most of our athletes were either in off season training for their respective sport, or our kind of military population doing some training and rehab at the same time. And then the other big part of our time was the NFL combine. So we would have anywhere between 30 to 40 guys transitioning from their college season to NFL, preparing for the NFL combine. So we would kind of treat them and rehab them if they had any injuries, and then also train them to get prepared for the combine experience. So essentially their interview to the NFL. So did that for about 2.5 years.
That's awesome. Walk me through that process of kind of being like a PT and a strength coach at the same time for high level athletes, if you can, Nate.
Yeah, and I would say I was working alongside a lot of the strength coaches there. So I wouldn't say that I was programming, but I was picking their brain, and then we would kind of, like I would say, like bridge the gap between rehab and performance. So typically what I would do, if there's a guy that was injured that wasn't in strength training yet, I would rehab him like you would typically think of. But then they're running at such a high level capacity, as far as getting their 40 to the tip top shape, getting the mechanics down and everything like that. If a guy was transitioning, I would kind of help with that transition stage. So as soon as they're kind of out of pain and everything there, I would be taking them through a few of the movement skills sessions, just like marching, skipping, resisted running, and stuff like that, until they could almost, and then some of the strength training stuff as well. if they weren't ready to integrate into the higher level training. So I would kind of offload the strength coaches who were kind of operating at max capacity as well. So I would kind of do the little lower level, modify their lifts and everything that they were doing to match up how the athlete was looking in rehab, and then how they were kind of moving as well, so that they would get the full experience of where training should meet where they're at in their rehab process.
Yeah, that's awesome. And I think that's really ultimately the future of, PT interventions, or just general health and wellness and fitness interventions for high level athletes, is kind of blending or blurring the lines between PT, AT, strength and conditioning, kind of bringing everyone together on the same page, because, the more eyes you have, the better. But also, I think the better the outcomes are, especially in the high level athletes like that. That slight difference that you can get by bringing everyone together. Maybe it makes 1% of a difference, but that 1% in a high level athlete is the difference between winning and losing on most of the occasions.
100%. And there's definitely times where, even for the healthy guys that weren't necessarily getting rehab, like a great thing like we did, like everybody was under one roof in that location. So like I was treating, it was almost like a training room experience ish. But the great thing of that building was our PT tables were literally, there's no barrier between the PT room, the PT tables, and the strength room. So there was no wall, there was no door you had to walk through. It was literally, hey, you can get off the table and you can walk over and do your set of squats or deadlift or anything like that. And then also the tables were lined up right along the windows of outside where they were doing all their movement skills. So we could, if we were working on somebody and a guy that we were working on was doing their movement skills, we could look out the window and see what they were doing. So it was a truly integrated system. And then when we were talking to the strength coaches as far as like what they were working on, if they were trying to get full extension on their backside and during acceleration, we'd line up, look at their move, see how they would move, see if they're missing any hip extension, and then kind of adjust what we needed to so that athlete could get the best that they could.
Yeah, that's really awesome. And, as we're talking here, I realize that, a lot goes into the evaluation and treatment and ultimately return to sport if the athlete's injured, significantly enough, especially at the high level athlete realm. And that's something that you have extensive experience with, working with, what you did in residency to what you did on the higher levels there up to the MLB level, and now you're continuing to do in private practice there, Nate. So I know most of your experience revolves around baseball and football and, different sports like that. So walk me through, if you're going to be working with one of these athletes and, say they have something significant, maybe it's an ACL tear or a shoulder surgery, like a labrum repair, rotator cuff repair, whatever it is, something that keeps them out of sport for an extended period of time, and then they ultimately need to return back to that sport. Walk me through where we start in that process outside of the, typical stuff you hear about initial rehab post-op, right? Like, I think most people understand the quad sets and most people understand, the passive range of motion of a shoulder. But from a big picture, overarching theme that you've had to, that you've had to explore yourself, where do we usually start that process at from your eyes?
Yeah, and I mean, it's nothing. I would say there's nothing like too sexy about the beginning stuff. It's literally just trying to get that body part moving again, get the body part moving, and then restoring your natural biomechanics, your arthrokinematics, and everything of the same thing. So decrease swelling, increase range of motion, and create some muscle activation at the very acute stage where somebody is just post surgery or anything like that. I mean, that's literally what we're trying to accomplish. So like I said, there's nothing groundbreaking with that, but just being on top of everything there. So like you were saying, for like, we can use an ACL for an example on that. I mean, you were talking just earlier before this about a knee injury post-op client that I was seeing that I saw for the first time, and she was 7 weeks post-op. When I first saw her, she was she knew what a quad set was and knew what a straight leg raise was, but she didn't know how to actually the quad set where she was supposed to feel it. So getting that mind body connection back to feel it in her quad and not in her patella tendon, it was huge for her because even before our session she would rep out 20 straight leg raises and not be fatigued whatever at all. But then when I got her to feel like what her quad was and then do a straight leg raise, she literally was shaking after 3 of them, because she wasn't using her quad to pull her up. She was just kind of using whatever she could to stabilize the full knee. So post-op or anything like that, I would say like literally just decrease swelling, get the muscles around it, the activation in the correct way, and restore that range of motion is where you're going to start off with.
Yeah, definitely. Those are very common themes early on in the process. Now, that time, we recently talked with Dr. T on the podcast about this. That time can be a very difficult challenge, I'll say, for especially high-level athletes from a mental standpoint.
Yeah.
What I mean by that is, they just lost total control of their situation. They used to be able to go out and play sport. They could pretty much do whatever they want, right? Some of these individuals are basically Superman, and now they might be dependent on someone else just to even move their arm for them.
Yeah.
So from your experience, what has been helpful for the athletes that you've worked with mentally during that time? And how do you help them continue to focus on, eyes on the prize kind of thing here, looking at the big picture and looking at ultimately return to sport while in the initial acute phase of things?
Yeah. So I think one thing, especially for an athlete, guys that like to compete, and they don't like being stationary. One thing that's super helpful, and this is helpful in several different ways, is finding things that they can do. So it's like for instance, like you're talking shoulder or anything like that, that might be in a sling for 6 to 8 weeks. They still have their lower body. So if we can figure out how to keep training and their lower body, I mean, that's going to keep them in activity. They're going to be able to keep their heart rate up, and obviously safely. So if they're in a sling or anything like that, we're probably not running too much where we're getting a lot of movement in the shoulder as well. But we can find ways to either load the lower body in different ways, as far as either through machine weight that's not going to be putting a lot of pressure on their upper half, or with a bike or anything like that. I think keeping them moving and keeping them kind of in their same domain that they're in a lot of throughout the day. So like in a weight room setting or on a field where they're surrounded by their peers, I think helps out a lot. But the second part of that too is like there's some research on like acute versus chronic workload, where if you completely shut down an athlete from all level activities, from injury post-op or anything like that, you're gonna have to it's gonna take a lot of time to build up that chronic workload again when they're ready to introduce that tissue back into lifting, into sport or anything like that. So one thing that's beneficial again is making sure the rest of the system, the rest of the body, is still going through a workload, so that you're not having to introduce stress to the whole body again, when just for one body part that might need to be at rest at the time. If that makes sense.
Yeah, it does make sense. And, I completely agree with you. And there's even some stuff coming out, at least in the ACL rehab world, where the importance of training the non-injured limb.
Yeah.
We continue to see more and more about that, where even just doing like, basic leg extension, leg curl, single leg machine on the other leg helps the operated leg.
Yeah.
It's kind of a bit of a rabbit hole and sidebar to get into the physiology of that. But in general, continuing to do whatever you can for people will help them physically, but it's also going to help them mentally. And
yeah, but even in that realm too, like if for an ACL or something, you still have the upper half too. So the lower part, you can get creative a little bit as far as how to stay aerobically fit or anything, like, because obviously you have smaller muscle mass, so you're gonna have to go a little bit go a little bit more and be cognizant of smaller muscles at work isn't going to be as aerobically demanding and stuff like that. But there's still 3/4 of the body that you can work on and not keep them completely out.
Yeah, completely agree. And one of the things we also talked about with Dr. T was the importance of setting goals, like large milestone goals, which is important for rehab as we progress from phase to phase, but then going back and breaking it up into step-by-step, pieces that we have to achieve in order to get there. So, with your experience with football and baseball, I'm kind of looking at shoulders, elbows, and knees being the three primary areas that get operated on, whether that be shoulder
Yep.
labrum, rotator cuff, Tommy John in the elbow, up to like ACL or meniscus in the knee. So with those three basic body parts in mind, what kind of things would you look for from a criterion or timeline or whatever progression you're using to get someone from what we call phase one to the next phase of your rehab with them?
Yeah, and I think he's absolutely right as far as like having goals in mind of where we need to get to, and then I think also working backwards plays a big role in this. So like we need to like knowing where we want to get to like get the athlete back to goes a long way. So with that being said, usually almost set our long term goals as far as like, hey, this is our criteria that we need to hit in order to return to sport. Now, what do we need to get to? When do we need to hit landmarks to progress them a little bit? So, like you were mentioning, knee, shoulder, and elbow as being three of them, and you can kind of look at them from a lower body standpoint and upper body standpoint. So, from a lower body standpoint, what check marks do we need to hit to make sure that this athlete is completely ready to go back to sport? So, at the very lowest level, we have to make sure is from a knee standpoint, we have to make sure the knee is good. So does it have full range of motion? Does it have full strength? Again, look at that from obviously range of motion, knee flexion, knee extension. Are those back to normal what they were pre injury? And then if you don't have the pre injury data on them, how much do they compare to the other side? And be very picky with this too, because it's very easy just to look at it and say like, yeah, it's fine because it doesn't have a hitch in it or anything like that. But if you're picking up a 1 to 5 degree difference on a knee extension post ACL, you might be missing quite a bit there. So being picky on that. And then strength wise, different strength measures as far as isometric quad, isometric hamstring, isokinetic testing as far as quad hamstring being 80%. From previous level or from opposite side. So those are just your kind of base low level, like, hey, we need to get this back to pre-injury for at the very least to return them back to sport. But then you also have to kind of think of, okay, that's essentially getting them back to what they were pre-injury, but why do they have that injury too? So, and this is, like I said, this is kind of returning to sport, but then you can make mile markers from it. So what's their foundational movement look like? What is their fundamental movement? Where are they missing a toe touch or a squat or rotation component? And then what components of the body is missing that? We probably need to restore that and definitely not be painful with any foundational movement. So we need to make a check mark on that. What's their motor control look like? Their Y balance end range, is their left side different than their right? If it was pre-injury, maybe that was a component that might have led them to injury. So we probably need to normalize that as well. Especially asymmetry and composite score together too. And then also especially for an upper body, sort of like shoulder and elbow, what's their upper quadrant Y balance look like? Is it symmetrical? Is their composite score good? If it's not, why is it not? Is it because they're not fully at full strength yet, or is it because pre-injury they're at risk even prior to it? And then we should probably get that normalized again. And then again, starting from the knee with looking at the knee, what's their hop testing look like? Their single leg hop, their triple hop, and their triple over crossover. Are those symmetrical? If they're not, we probably need to get that symmetrical as well, because and when you start to look at this, each thing's kind of building on itself. So like what you'll see a lot is for an ACL or anything, like if there's triple leg hop is asymmetrical, is their Y balance asymmetrical? And then one's at a little more control than the other one, or at a slower pace. Is that where the hiccup is? Is that where we need to stay? And then also quality and quantity. So for a triple jump, single leg hop or hop, sorry, single leg hop, are they going into valgus with it? Can they prevent that? Or they might be symmetrical, but their surgical leg is keep diving into valgus. So truly, they might be able to produce the power, but they can't control it then. So all these things you're kind of looking at and goal in mind, getting them back to sport. And then even when you check these objective steps off, you still have to do the progression of return to sport as well, making sure that they're not getting sore, making sure they're able to complete sport specific activities in a progressive manner, so that again, it's kind of like the acute chronic stress workload is we're not just progressing and saying like, hey, you're good on this, so just hop into sport. There still has to be the progressive return.
Yeah, I completely agree. And I love all the different batteries and outcomes that you just mentioned there, Nate. There's really a lot that goes into sport. And I think that a lot of practitioners, at least from my experience, forget that, right? Like you threw out the Y balance test. And the Y balance test isn't something that we should just reserve for ankle or knee injuries. I think the Y balance test, even the lower quarter one, has value and insight that can be helpful for upper extremity injuries, right?
Yeah,
Because
yeah. I think there's a study on the lower quarter having a correlation with UCL injuries. Uh,
that's the kind of thing. It's like if we're missing that or skipping that, then we're ultimately doing the athlete a disservice because we haven't really looked at or assessed everything that they need in order to return back to the sport. And I know it can be a lot, and you don't necessarily have to do every single test under the sun in order to feel like you're ready to return an athlete to sport. But ultimately, you need to make sure that you assess everything in some manner, in some fashion. And while you just mentioned a lot of different objective focused things, right? Like
yeah,
the numbers on the Y balance. You also mentioned that it's not just about how far they get or how far they can jump left versus right on a jump test or a hop test or that sort of thing. It's about what it looks like when they're doing it. Does
yeah,
compared to what you would expect them to be doing or other athletes in a similar sport to be doing. And, unfortunately, you might not have been able to get a good depiction of what it used to look like because, if your pre-op assessment was them hopping on a torn ACL and now they're hopping on a functional ACL, I'm sure it's going to look a little bit different. I would say the other piece too is just the importance of the subjective side of things. And this is something we continue to bring back up in the podcast is, plain and simple, if an athlete looks at you and says something's wrong or it doesn't feel right or it hurts, they know their body better than you do. You can't, explain what they're feeling
100%.
for yourself. So there's an important conversation that needs to be had, I think, about just listening to the athlete and what they're telling you as you progress them to, a higher level sport or return to higher level sport activity.
Yeah, and I 100% agree on that. And there's also the like FABQ and fear of avoidance of movement and some of the psychological edge that should probably be kind of thrown in that objective stuff. But what you were saying in psychological or not psychological, sorry, what the athlete's telling you on subjectively goes to far distance. Like I remember there's been times where all this objective data and that I test. And I remember sitting in front of an athlete saying, "Hey, you're passing all this stuff. You're good." Now this is me trying to like thinking not like try to pump them up and kind of like get ready to go, but like they were a little hesitant about stuff. I was just like showing them like, "Hey, like this is," and it was after a major surgery too. I was like, hey, you're showing me that you're ready. Um, that everything that I'm looking at is showing me that you're ready. But they kept kind of voicing like, hey, like it just doesn't feel. It feels like I have to hold back on stuff. And this is like a baseball player coming back from a UCL, and it's like learning from that experience as far as like, hey, they're feeling something. Like sometimes the greatest power that you can have in empowering the athlete as well too is like listening to them and figuring out like, hey, sometimes it's not all objective stuff. Sometimes like their body is telling you like maybe the tissue is just not healed as well as what it should be, but we could um, quote unquote hack their body to pass some objective data that it's all encompassing. So you have to talk with the athlete to figure out like if they're do they actually feel ready to go, and if not, if they don't feel ready to go, you have to meet them where they're at still, and that's completely okay too. That's actually what I would almost argue that that's what you should do, because they're like you said, they're the ones that know their body. They know if something doesn't feel right or not.
Right, and as you basically just alluded to, is you can't just put the same timeline for healing on every athlete, right? Like
Yeah,
maybe an ACL graft kind of integrates a little bit earlier than you expect, or maybe it takes a little bit longer. Well, same thing could be true for the UCL, or maybe they had a more complex labral repair than someone else, and they need additional time. And you have to be able to break down and individualize your progressions and interventions accordingly. And if you're not, then once again, I feel like you're doing the athlete a disservice by trying to tell them and lump them in with
yeah.
everybody else, because no two athletes, at least in my experience, have presented 100% identical thus far.
No, not at all. And that's the fun of what we do. Is we can try to objectify everything and everything that we want to, which is what we should to have the best data to go off of. But then like you said, no two treatments going to be the same because guys are going to present a little different, and then they're human as well, so their tissue is going to change a little bit different than somebody else's. So you gotta kind of get to adapt per person and figure out something new and then grow as a clinician as well. Then after you work with them.
Definitely. And, as we're talking about all these different objective measures and tests and different things that you can do, I know someone listening or some people listening, they might say, well, I only have 40 minutes with my patient in an outpatient facility. I can't
Yeah,
get all of that in one or two visits, even sometimes, or I might not see my patient that long, or, how else can I see progress or track progress without doing formal testing? And I'm curious to hear your thoughts on basically looking at the interventions that you're doing on the day to day as a sign of progress, right? Like, how do we go about looking at something like maybe a double leg squat? Maybe the first time we do it with a post op ACL athlete, they're 45-pound, just empty bar. And before you know it, they're at, 185 for reps. How do we
yeah,
go about looking at our interventions as a way to show and track progress?
yeah. And I think one thing that I've figured out as far as like I can't say I figured out as like completely this is what it is, but obviously we grow as we go. But one thing that I've done, especially for the objective data, is like try to pick up as much as I can each time I see them. So it's not like, hey, I need to pick up all this stuff, this whole list of stuff that I mentioned earlier at one time. Because you still have to get treatment done, especially if you're only seeing them once a week or twice a week. You don't have every day to do it. You can pick up like say it's like hop testing or something like that. Say they've cleared found it like you've progressed them enough that their knee range of motions all the way back to normal. Their knee strength is back to normal. Their fundamental movement, functional movement screen, they may be limited in their squat or something like that. Or but at least no pain or something like that. And we're starting to load the joint a little bit. You may be able to just like have them like test the squat at the beginning of it, and then say like we look at hop testing and then we look at a squat. But then that hop testing may like we probably don't have to test that every week or every time we see them, but you can look at the next time you come in like all right let's look at the Y balance. or something similar. So like you can knock off different things at different times to get the whole kind of checklist of what we need to hit. And then once you get a higher level, we can kind of cross off the lower stuff that we don't necessarily have to hit every time. But then we check in every once in a while to make sure that they haven't gone back.
Yeah,
But
I like that. I like that a lot. And the other thing I've seen people do lately, and I'm starting to incorporate more of it as well, is include RPE in your sessions, right?
yeah,
It's very simple to ask someone, hey, 0 to 10, how difficult is this today?
yeah,
And, plain and simple, if you're looking at the long-term game, someone could start with 10 out of 10 RPE squatting 135 and end with, RPE at 2 squatting 225 for reps.
yeah,
Or same thing for, any exercise that you're doing. It's a very quick and dirty way to show progress, but it's also a great way to get immediate feedback on how your patient is doing that day.
yeah,
I've even talked with people in the past that use some of the different outcome measures and tests that you mentioned almost on a daily basis as a way to track where that athlete is, is on that day, right? Like, I think it was Joe DeFranco, and I could be wrong about this, that uses hand grip strength as a way to
yeah,
monitor recovery. So,
yep,
squeeze a thing, get your baseline, and then every time you come in the gym, squeeze it as hard as you
yeah.
can. What's our number, and how do we adjust our load accordingly for that session?
Yeah, and there's if you start getting into tech, there's a lot of different ways you can do it. As far as like if you have force plates or anything like that, you can just look at a counter movement jump and track how much force goes into the plate. Hand grip has actually a pretty like you were saying, a pretty substantial correlation as far as like how primed the system is. Your body is ready to accept load that day, and you can see the fluctuations if you track it from a day to day. You'll definitely see fluctuations of how drained a guy is, how much sleep that he had, what was his recovery the day before, or anything like that. As from a performance metric or performance, how ready they are for that day.
Right. And if you're in some of these different high level settings, whether it's with a professional team or professional athletes, or maybe you're just, lucky enough to be in a private setting where you can work one-on-one with
Yeah,
maybe 5 or 6 patients a day, and that's a full caseload, you can really dive into the numbers there and kind of look to correlate numerical data on that kind of stuff with their performance metrics as well. I think a lot of people wear, some kind of fitness watch or smartwatch or something like that today. You can get all kinds of data from sleep to heart rate
yeah,
variability on an Excel sheet real easily. And it would be kind of cool to explore the overlaps between what's going on for them physiologically, what's going on with them on the day to day when they come and see you, and then what happens in the long term or the big picture from that, right? Are
yeah,
the athletes who are sleeping less the ones who struggle to recover more, or
yeah.
from a surgery, or the ones that are more stressed, or what have you. And while I could sit here and make assumptions on those things all day long, again, we don't know it to be true until we prove it.
Right, 100%. Yeah, and then like you hit the nail on the head as far as like wearables or anything like that. You get so much information from them, and as long as it's consistent with it. So like as long as you're not going from like a Garmin to an Apple Watch on a different day and stuff like that, that can provide quite a bit of information that we can use to help program that to help program an athlete at least.
Definitely.
And then you mentioned RPE. I was gonna say that's one big thing too, like as far as squatting or anything that um, for throwing, like on a return to throw as well. Um, it doesn't have, I can't say it has like the best correlation with it. But as far as like somebody that doesn't have tech, like say they don't have a radar gun that you can use, which would probably be the gold standard as far as like how much of an effort somebody's throwing, you can still use RPE to start throwing progress back or to start the throwing progress or cut them off as far as like, hey, we're only going 60 feet today, or hey, we're only going 45, 50 feet today. Like that in itself is going to be a limiting factor as far as like how much intensity they're going to have.
I'm glad that you brought that up there, Nate. I mean, as we kind of transition into more of the sport phase here, that return to throw for baseball or football, and the return to football or return to soccer or whatever for a knee injury. Those are huge steps and huge milestones. And ultimately, we need to have some kind of progression set up where we can take someone from level 1 to level 100 if that's how far they have to go with that. So where do you like to start, and where do you like to, progress people, or how do you progress people from either a return to throwing or a return to lower extremity dominant sport, I'll say, after one of these injuries in the late stage kind of rehab process?
Yeah, for sure. So I think, like I said, you have to kind of have the end goal in mind, and then pair up what you're getting objectively into their training to get them back into sport. So if we're looking from a typical, like just a progression, so sport progression. So they're say they're hitting everything that I'm checking for objectively at the time. So like if I'm looking at a return to sport progression, then we'll say kind of like your lower extremity return to sport. One like big things that I'm looking for is like, one, do they hit all the objective measures that I'm looking at, and two, like the return to sport, like, so can they handle? You have to be able to handle more load than body weight prior to doing anything like very dynamic. So can they handle isometrics at a little bit of a higher load, especially starting with body weight? Can they handle isometrics body weight in different positions in different patterns? And then and then again, I'm matching all this stuff up with how they're moving. So like, if their FMS isn't clean, or if they're having struggling touching their toes or something like that, I'm gonna adjust their strength training appropriately to meet them where they're at. But so are they matching? So to begin strength training, do they have foundational functional movement? Is that clean? Is their joint moving to its full, what it should be moving as, and are they respectively strong in that joint to begin load? So then you start loading it in the weight room because it's controlled, and you can control the amount of forces that are going through it. And they should be able to get back into a full strength program and accept the load before you start doing any type of dynamic exercises, meaning like hops, jumps, or anything like that. So like, and of course there's gonna be some gray area in this, that there's nothing that's gonna be like absolute of saying, hey, you have to be able to squat what you did prior to injury before you can do any hopping or skipping or bounding or anything like that. But from just a on paper standpoint, can you do stuff under load, and then start progressing strength from there? Once you became integrated back into the full strength department, can you start implementing speed to it, and from either load acceptance or force absorption or force production. Typically depending on the injury, you would kind of want to learn how to absorb force before you produce it, because you kind of have to absorb it once you produce it. So like I said, pending injury on that. And then once you can do pre-programmed stuff when you're back into some single leg stuff, some double leg stuff, then you're implementing some back to single leg stuff. Then can you work on pre-programmed athletic movements? So, or change of direction would probably be the better term on that. So if you can go linear, then you can start going into change of direction. But of course, like I said, it's got to be pre-programmed, where the athlete's not having to make any decisions on it, where they just know what they're going to do prior to that movement. That way you're taking their mind, most of their mind out of it, and just letting their body move. And once they get good with that, then you can introduce the kind of random acts. So then that way they're having to make decisions, and they're not ready to. It's not, like I said, it's not pre-programmed. So now it's random. And then once you have that, then you can start adding some variables to it and adding some perturbation and stuff like that in movement, and then introduce them back into their skill, what they're trying to learn. That's kind of more of like a lower body type scenario.
Yeah, I love that progression you just outlined, focusing on the lower body there, Nate. And I think plain and simple, as you mentioned, you have to get the strength first, because if you're
Yeah,
strong, then other things probably won't go well. We'll just
yeah,
put it that way.
yeah,
And
and that's the same way as far as like you got like matching the athlete with their strength as well too. So like it's like if you're trying to load somebody and their body's not in a capacity like for like a squat, for instance, like and they don't have the hip flexion, ankle dorsiflexion, stuff like that for the squat, it's like you're not loading that joint appropriately anyways. So like getting the foundational movement down and then getting the strength behind it's gonna go a very long way.
Right. And then taking it a step further, as you mentioned, the importance of mastering the ability to slow down and decelerate before we overemphasize the importance of acceleration. I think everyone wants to be a faster athlete or jump higher or be more explosive. But from an injury standpoint, most of the non-contact knee injuries I see, at least speaking for myself here, are deceleration or
Yeah,
slowing down when we start to change direction. And yet, for some reason, we don't emphasize that in a lot of strength programs and training programs. So, spending a lot of time on that is certainly a good thing. And as we mentioned before, the importance of, as we progress back into those things, double checking, how is your athlete feeling? How does it look like they move? How does it look like they land? And then as we progress, doing so in a systematic way, kind of like you just outlined, right? So,
yeah,
before we return to run, maybe we start doing double leg box jumps at some point, because, hey, running is a single leg force absorption activity by nature. And if we don't feel comfortable doing that on two legs, one leg probably isn't going to go well. And hey, before we add in multi-directional movements, let's master forward and backwards first. Hey, you just mentioned earlier about the importance of making sure your athlete knows and understands what they're going to be doing. It might not hurt to throw in a little visualization and say, hey, look, I want you to picture yourself doing this. Here's what you're going to do. Now do it. Hey, can we have the PT
yeah,
demonstrate it, just so they, eliminate their guesswork? I think everything you mentioned before on that progression is phenomenal. And I think that a lot of people often miss steps. And, I know I've missed steps myself in the past, and it's okay to not be perfect, but, we ultimately have to be able to look back and reflect and learn what we have to do in order to be better providers and better serve our athletes.
yeah, 100%. That's where I think like having a good system in place for yourself, and knowing what you prioritize before you hop to the next step goes a very long way as a clinician, because I've known several different ways, right? And when I look back on myself, where I almost felt like when if I see somebody, I felt like I was like, oh, they just need power in their leg. It's like they're presenting to me every time. It seems like they are trying to jump off their left leg. That's when they always have the problem. And like even knowing like a great system that I had set up, as far as like I listed out everything that I needed to get under like the base layer stuff, and they may be missing one or two there. I was like, as a younger clinician, I was like, well, they just need the power. I was like, I think I can just work on the power. Like keeping yourself true to your systems typically goes a lot further than when you try to make changes on the fly, because like I can look back on those instances where I was just like, all right, we'll just do a whole bunch of like jump training with this guy because this is what they need. And I think I did them a disservice, because the lower level stuff that was missing was what they needed, and they weren't getting better until I circled back up on the ankle dorsiflexion that the guy was missing before we started power training, which ankle dorsiflexion and then squat and then strength training and then the power. Like that went a lot quicker than me just trying to be like, hey, we're gonna have to jump a lot. So learning from those experiences have come a long way.
Definitely. And recognizing that, some of those interventions might not be the cool, sexy things you see on Instagram all the time,
Yeah,
but they're essential, and even just kind of revisiting your progressions and almost rebuilding them in some senses, right? Like,
Mhm.
you might have a progression for bridging, for example, where you go
Yeah.
double leg bridge to double leg with Breuger modification or adductor squeeze or whatever to single leg to this, to that, to the other thing. And you might find that you have to add in a little variety in that progression, right? Maybe you
Yeah.
have to have them hold their heel up off the ground and do a double leg heel float bridge before you move on or something similar to that.
Yeah.
And it's always just constantly a system of, revisiting your own process of progression, which I think that will serve you the best in the long run. We mentioned
100%.
we
And
mentioned
especially when you know where you're going. So like where you're trying to accomplish, because there's been many times where I've been seeing a person in a clinic where I was like, I look at all their movement patterns and I look at where their strength deficits are and I look at where their range of motion deficits are. And I was like, I think this exercise right here is gonna benefit them. And I'll take them through it, and if it looks like they're going whatever the exercise it was, at the end of the day, it really doesn't matter because it's like as soon as you see them do it, and then you kind of recheck, and it doesn't make a change. Whatever change you were trying to make, or what I was trying to make, it didn't happen with that exercise. And I was like, all right, well, I thought they were a little too lower level than what they were. So then you make the adjustment on the fly and be like, progress it a little bit, see if you made a change. If you did, great, that's where they're at. Progress it a little bit more, see if you made another change, and then keep going where the athlete's at. So it's a constant battle of like, hey, are you making a change within the session, or are you not? If you're not, just change it up. You were wrong. That's okay. It's just as long as you don't stay there.
yeah,
Just keep meeting the athlete where they're at, and then you'll get better success from it.
completely agree. And I don't want to get too lost with the rabbit hole I'm about to start on, but just understanding what you're doing and why you're doing and what it's doing, right? What does three
Yeah,
sets of 10 mean? What is that going to do? What is a single leg unloaded bridge going to do for someone over a double leg barbell hip thrust? What are you
yeah,
doing with your intervention and why are you doing it and what benefit do you expect that to provide? Because a lot of the exercises, or I'll even argue that a lot of PT in general is neurologically based, right? We
yeah,
have a lot of movement rewiring or movement hardware or neurologic based approach to the exercises that we do. You're not going to convince me that 3 sets of 10 clamshells is going to change anyone's life or that alone is going to, boost their glute strength or anything. But if it changes some kind of neurological firing pattern and makes them move better, then there's value in it.
yeah.
Um,
Which
now,
I mean, yeah, I was gonna say we can go down a rabbit hole on that as far as like I was like, if you see somebody for 6 weeks, any type of we know on motor recruitment versus hypertrophy of a muscle, it takes 4 to 6 weeks before we see any type of muscle change as opposed to neural recruitment. So if we're actually working on neural recruitment and we only see them for 6 weeks, see patients for 6 weeks, are we truly working on strength or are we working on neural neural recruitment? So if we have them for 6 weeks and we're working on neural recruitment, are the 3 sets of 10 really what we need? Or is it, yeah, there's a whole different rabbit hole that we can go down as far as programming,
we'll
programming
have to
for patients too.
we'll save that rabbit hole for next time. I really want to get into the upper extremity progression next, if you don't mind, Nate. We did a lot of good work there hammering the lower extremity, but how about someone, maybe they had a shoulder or an elbow or whatever, and they're looking to progress back to that throwing? What's your kind
Yeah.
of steps that you would take there?
Yeah. In some cases, it's gonna look the same as from the lower half as far as like just the landmarks. So like obviously like the same lower level impact is going to be just like the same as like you have to restore the full mobility of the joints. So if we're looking at elbow, do they have full flexion? Do they have full extension? Do they have full pronation? Do they have full supination? And then do they have the strength on there? So um, grip strength, shoulder strength, looking at all that, and then also still some movement patterns and everything. But if we're looking from, it's like I don't want to miss that we're looking at that objective data too. But if we're looking from a pure like return to sport progression and still looking at the objective data, I'm still going to be looking at that objective data while I'm getting them back into sport and stuff like that. But from a pure like return to sport, um, to get them prepared to throw, like say we're going to get them to throw, one, again, you have to be able to accept a load. So I usually like to get my athletes back into upper body strength training before we start to throw, because that's still load but in control. You're not doing it at a high speed. You're not doing it that dynamically. You're controlling the load either eccentrically, concentrically, isometric, and you can make the case for however you wish to program, where it should be like isometric, eccentric, and concentric and stuff like that. Like they should be getting back to strength training before they start to load. But then once they've done that, and you're still, like I said, you're still looking at their objective data, their grip strength, shoulder strength, range of motion, foundational patterns, motor control. Before they start throwing, you're still going to have to get them into some sort of what I call like arm patterning. So what I really enjoy is, like, you can have different things of co-contraction, of like you can have plyo balls up against the wall, tapping on there to get co-contraction, open chain stability through there. One thing that I feel like is almost a must before I throw anybody is I like to use Indian clubs, which gets you back into the throwing motion, but you're not releasing anything. So you're going into circles, you're going into kind of your Indian club step backs, your slams and swings, where you're still having some control, but you're starting to get a little higher intensity movements in there. And then also some like kettlebell stuff where you're holding on to some dynamic, where it's offset and everything like that, where you're still working on kind of grip strength. So once they demonstrate that to me, as far as like, hey, they can accept this load, and then also you can kind of do some like non-throws too. So where you just don't release the ball. That's gonna be kind of a little bit of a self-limiting. One thing I will say, I do like to do a lot of like opposite hand throwing prior. So like after a UCL or anything like that, once they're able to start kind of running, I'll start doing some, like if they're a right-handed thrower, I'll start doing some left-handed throwing, because that's for a lot of different reasons. One is just like same thing as what you were talking, as far as left-sided ACL or opposite side ACL training. When you're getting back into it, there's some nerve development from cross sides, but then there's also kind of you do so much rotation from right side, it's probably good to even it out from the other side, especially from if they're not throwing with their current side. But then once they get to throwing, you're gonna have to start building that workload. So typically starting, depending on the level, high school, whatever, 45 to 60 feet is typically where I start a thrower, and then start progressing from there. Volume, distance, intensity. So looking at, if you have a radar gun, use a radar gun to correspond like what the intensity they're throwing at. If you don't have a radar gun, you can use RPEs, you can use distance, you can use, there's some have used like throwing into a net as opposed to throwing at somebody to decrease their RPEs, and then starting to build tolerance from there. So one thing you look at, if this is a major injury, you might want to start looking at that. Well, as far as the acute, like I talked about, kind of the acute chronic workload ratio, you can have gross body that way, but then you can have the tissue itself. So like localized, so global acute chronic, and then you have local acute chronic. So you probably don't want to increase too much. Like there's always that 10% rule, which is disputed a little bit, but you don't want to increase stress at say it's a UCL. You don't want to increase stress like more than 15% in one week to the next by volume or distance. So tracking number of throws and number of distance and how far you're throwing goes a long way into progressing the next week or the next day or anything like that. So then once you start progressing distance, then you have when you start long toss, and then if you're able to accept long toss, then you start going into mound work, and then back into considering hitters and game situations.
Yeah. So what you explained there, Nate, is it sounds like we start with that base level of strength, and then we kind of progress it to the point where the strength becomes a bit more, I'll say, specific in comparison to the demands of the sport. So
Yeah.
where do we need concentric motion in a throwing, in a throwing arc? Where do we need eccentric motion? What muscles? How are they going to be firing? And then we hammer that from a strength standpoint, and then slowly reintroduce and progress back. And I like how you mentioned the importance of starting at like a comfortable distance and throwing and then progressing up to long toss. Hypothetic or theoretically speaking, 45 feet is a pretty short distance for a
Yeah.
baseball to be thrown. Especially when you look at some of the outfielders that have to throw the ball 300, 400 plus feet. And, correct me if I'm wrong, but I think that the long toss is an essential element of pitchers as well. I mean, there's pitchers that do a lot of long toss to build up
Yeah.
movements for the arm.
And you'll see certain guys do different things. So this is kind of like meeting the athlete where they're at too. So meeting a pitcher where they need to get. So there's a lot of pitchers that don't necessarily throw past 120 feet. And this is pitcher preference. They'll get all of their high intensity throws on the mound. So they'll say like, hey, I don't typically go past 120. But then you also have some guys that will throw out 200 plus from a pitcher standpoint, and that's the only time that they'll feel good. Now, whether they're doing themselves justice or not, you have to figure it out. But you also like it's their livelihood too. It's their body. They're the ones that know when they feel good and stuff like. Especially if you're working at a high level guy, if you're not on a professional level. If you're working with like a professional pitcher who made it to the pros and they throw out to 250 the day before a game, like it's gonna be hard for me to tell them like, hey, you're doing it wrong, or anything like that, especially if they made it that far. So giving them the tools and everything like that to know how to recover from that, like depending on what maybe it's just as simple as like, hey, instead of 250 the day before your game, maybe we'll do that another day. May go a long way in the development of them and the injury prevention from them as well. But when they're younger, like a high school athlete or something like that, high school, middle school, and they're starting to throw one like 60 feet might not be that low level for them. 45 might actually be a good starting place for them, especially if they're just starting to throw and they're just trying to get the arm mechanics down. But just depends on the age and depends on the athlete.
Yeah, definitely. Going back to what we talked about before about the importance of individualizing your approach. And, Nate, I feel like we could probably talk about this all day long. There's so much detail and information to, get from considerations when an athlete is returning to sport. Before we kind of start to close out and wrap up, though, I have one more really important question is
Yeah.
these different tests, all these different progressions are amazing. They're incredible. And most of the time they work.
Yeah.
Now and then you get an athlete who comes in and maybe it goes well for a while. Maybe they progress back. Maybe they even get back to sport. And then it doesn't always go 100% picture perfect from there. Maybe there's regression. Maybe you have to take a few steps back. So what would you do? I don't want to use the term failure, but what would you do if you run through all of these different things? The data looks good, they feel good, and then you get them back to the sport, and then something happens and it doesn't go as you expected it would. Where do we kind of go when we come up a little bit short from where we expected we would?
Yeah, those situations are always kind of hard. Like you always, so that's when you kind of that's when you take a lot of time like not contemplating, like looking at yourself, like what went right, what went wrong, seeing how things you could do differently and stuff like that, and what you can change and different things. So you're already self-evaluating like what you could have changed, what you could have done better, what you could have done, stuff like that. If some things don't go as planned, but then like within that situation too, speaking with the athlete may go a long way. So that's when, like we talked about earlier, if the athlete maybe they were maybe they weren't as confident as what they presented as. But you see a lot. You see a lot of athletes though that come speak to you and they're just like, yeah, I was ready to go like eight weeks ago, but you kept holding me out. And then they get onto the field and things aren't going right, and they come back and they're like, yeah, to be honest with you, I really wasn't feeling that great, but I wanted to get out on the field. So like finding out where the downfall may have been, maybe, or maybe if you missed it, maybe you were a little lax on your testing and everything like that. But then also understanding within yourself that there's a lot more. We're trying to control a lot of different variables, but we're still not looking at everything. So like, did they? And that's where the reflection comes from. So like, did we educate them enough on sleep and recovery, and eating, nutrition, and everything like that? If we were just looking at our musculoskeletal objective data, but not educating on any of that, and they went back, and then to find out that they were only getting 4 hours of sleep the entire time you're doing that. Every time you were rehabbing and then went out, well, then maybe it's a sleep problem. Or if they're eating Cheetos every day for their lunch, then maybe that was your problem. I don't know. But then also, like I said, take for granted, we're dealing with humans as well. So we're not going to be able to control every variable, but we can at least control what we can control. But still learn from the experience of like there's not too many times where I discharge a person and be like, what could I, and not think of like what could I have done differently. So if there was a setback or anything like that, there's a lot of self-reflection of going back of like, hey, what's different and how do I improve upon this? And I think that's probably a very good thing to have, so that you get better as a clinician and then you can help the next person that comes in front of you.
What you just explained is what separates the good from the world-class clinicians. And, you mentioned you yourself do it, and that's what makes you so effective. And I think that's probably in part why you had such success working with the high-level athletes, Nate, is you can't just, run through the motions and then skip the reflection phase, because we call it the practice of medicine for a reason. We don't have all the answers. We don't have it all figured out. And, I think in that process too, it's important to note that, you are not like, I'll use the term failure now. You shouldn't consider yourself a failure if you run through this whole rehab process and that sort of thing, and they go back to sport and it doesn't feel 100%.
Yeah.
That's not on you in every case. I mean, unless you blatantly do something ridiculous, like, like return someone to sport post-op ACL 2 months after surgery.
Yeah.
Like, unless you do something like that, some of these things are normal.
Yeah.
It's normal to be a little bit fearful the first time you play a game after a major surgery. It's normal for someone to have a little bit of discomfort the first time they go back. And that doesn't necessarily mean that you as a clinician have failed the athlete. As long as you are taking the time and taking the steps that you need to turn around and say, what could I do better so that the next time I treat an athlete with this, I'm 1 or 2% more effective. And as long as you continue 100%. To do that, as long as you continue to do that, I think at the end of the day, you can sleep good at night and you're serving your athletes very well.
Yeah. And I think you said it very well there. As long as you're getting yourself better, like you're not going to be perfect with everybody that you treat. But as long as you're making strides to become better, I think you're on the right track for at least becoming better, because you're trying to get better. So yeah, I would agree with you 100% on that.
Now, Nate, as we start to wrap up here, do you have any kind of connections, or are you on social media, or how can people find out more about you or reach out with questions and see what you're up to?
Yeah. So I have a Facebook, Instagram, and Twitter. Instagram is at integrated.performance is my Instagram. Twitter is at Nate_Denning. And then Facebook is just Integrated Performance.
Gotcha. We will link to all of that below in the show notes. So if you didn't quite catch that, you can just click there and check out everything Nate has to offer and everything that's going on over at Integrated Performance. Nate, do you have any kind of last minute closing thoughts or closing remarks that you want people to really take away from this?
Yeah, I think the main thing that we kind of touched on was just making sure that you like discover your system out that you have and abide by it, and then constantly kind of just make tweaks to it so that you know where you're at, where you're wanting to go with your clients, so that you're getting them to their maximum potential. But then know that you're always making changes based off what we just talked about, as far as like if you don't have a successful outcome, how can you improve your system? How can you get better from a clinician, and definitely reflect on each person that you're working with to better yourself so that you can give the most to your clients. I think that goes a long way.
It definitely does. Nate, really appreciate all your time today on the weekend, nonetheless. Thanks for jumping on, and thanks for all the insight and knowledge that you shared today.
Yeah, thank you, Dan. I appreciate being honest. Great talking with you. Can't thank you enough for this.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.